tonight's speaker. Dr. Hanisee is a general and bariatric surgeon with South Georgia Surgical here in Thomasville. She earned a bachelor's degree from Centenary College in Shreveport, Louisiana, and her medical degree from Louisiana State University in Shreveport. She went on to complete a residency in general surgery at Louisiana State University in New Orleans and a fellowship in bariatric and minimally invasive surgery at the University of Maryland. And she is also the medical director of our Archbold Bariatric Weight Management Program. Please help me welcome Dr. Hanisee.
Hey guys, how's everybody doing? Good. I'm Katie Hanisee. I got started here back in September. Part of the reasons I was so excited to come here is that there was no bariatric program in place. And so I am so excited to be able to tell you that we've been doing our first sleeves here. I've done plenty before here, but our first sleeves here were last week, and they went really well. So just to introduce you a little bit to our new practice, there's myself, of course, and Ashley already gave you an awesome introduction for me, so I'll bypass that. But I also have Jennifer Lewis with me, and she is fantastic, and she is great with patients, and she cares a lot, and I think she's a great asset to our team. In addition, we have the luck of having Gina Smith, who works in the hospital as a dietitian. She also works in our office and comes over and does our bariatric clinic with us on Tuesday afternoon. So when you come to see us, you'll see me, you'll see Jennifer, and you'll also get to see the dietitian all at the same time. So we're going to do a little bit of a broad scope today, talking about, what is obesity and why do we care about this? What is what are the benefits of thinking about bariatric surgery? Obesity is a disease when we have excess fat storage, and unfortunately, that alone is not a problem, but it is linked to several comorbidities, and those are not just associated with obesity, but it does not make anything better, okay? In order to be considered morbidly obese, the standard that we use most often now is a BMI over 40. And if you have a BMI over 35 with a comorbidity, that also puts you in the category where we can start to discuss our options. What we use just so you can have a little bit of information on how we dictate what these numbers are, up to 25 is considered normal weight, okay? Once you get to 25 to 30, you're in the overweight status. And once you hit 30, you're considered obese. Keep in mind, between 30 and 35, we do not qualify for bariatric surgery. So it's not until you get to that 35 marker, and you have to have a comorbidity at that time that's significant in order for us to be able to evaluate you. I say that with the understanding that before you get to that point, there are lots of things you can do to hopefully prevent being in a situation where that's something you have to think about. Diet and exercise obviously are not the easiest things in the world to do, but they are very important. So kind of assessing your health and seeing where you are before you get to a point where you may need surgery, or maybe even an applicant for surgery, is an important part of your health. So obesity is a very complex issue. A lot of it is genetic. There's a lot of it that's behavioral, and there's also the situations that we're in or environmental. So it's not just one thing we can talk about. We know that kids of obese patients are 85% more likely to be overweight. So while there is some genetic factor there is also the behaviors that we learn. Some of the comorbidities that are associated with obesity, and this is why we care about it so much, are type 2 diabetes, high blood pressure, hyperlipidemia. You can have asthma or respiratory distress where you can't quite breathe enough to get the oxygen that your body needs. Sleep apnea is a big issue that we see commonly. Depression, reflux, and joint disease, those are the most common ones. Other things we do see are urinary incontinence, fatty liver, gallstones, heart disease, coronary artery disease, and stroke. I should mention that fatty liver disease is the most common need to have a transplant these days. It used to be cirrhosis, but now we see it more with fatty liver. So it's definitely something that's on the radar on a national level. At this point, 65% of adults are overweight, so if you keep in mind that was the over 25 category, and 32% of children are also in that category. 4.8% of adults are morbidly obese, and I think that number is actually up now. Total medical cost for obesity in 2003 was $75 billion. 325,000 obesity-related deaths occur every year. And the reason that this is important is they're able to identify, first of all, we know this is a problem and it's causing a lot of issues, but also it's costs a lot of money to both insurance companies, to hospitals, and to the government. And so that's why they've invested and are willing to cover these procedures. There are a lot of people that are facing the same issues. So if we look at this map from 1987, we can see that there are a lot of areas that have that lighter or middle blue number, which is 10 to 14% of people in the same situation. As we progress to 1997, we can see that we now have some yellow, which is 20 to 25% being in a situation where they have morbid obesity and have some issues associated with it. When we get to 2007, we can see that it is obviously a widespread issue throughout the country. I don't have 2017, so I apologize. They haven't come out with that information yet, but as we can see, it's not a problem that's going anywhere. In addition to medical costs and medical problems that we have that tend to shorten our lifespan, there are other psychosocial issues that people struggle with, and that has to do with things that you encounter on a daily basis. Are you going to be able to make it up the stairs to the concert you want to go to? Are the seats going to be big enough? Can you fit through all the turnstiles to get there? And so it's something that not only affects our health, which is so important, but also our psychosocial mentality and how we think about ourselves, which I would argue is just equally as important. So we also, as we discussed a little bit earlier, in patients who are younger and middle-aged women and men who have increased BMI, they've also increased their chance of dying prematurely. And teens entering adulthood with a BMI over 40 die 8 to 13 years earlier than the general population. While that's not something we address here, we do adults here, there is an increasing opportunity for actually adolescent bariatrics. They have great results. As you get them earlier and they really adjust their mindset earlier, they're doing really, really great. So we talked a little bit about the cost in general, but if you think about things like conventional diets that people try, buying books, buying shakes, buying all the other things that we try, having to go through different sizes of clothing, the expensive food, not to mention your medications and things like that. This is some information that we get from an HMO, basically saying the cost of a patient with in that over obese category, 30 to 35, and then super obese over 35. So you can see even in that obese category, where again we don't qualify for any kind of intervention, it's still 25% more compared to a patient who has a BMI 25. And you can see how with 35 that number goes up even more. So just to talk a little, we kind of talked about why it's an issue, why we care about it. So we can talk now a little bit about what are the options that you have if you did want to try surgery. I'll precurse this with saying we have a pretty good program here where we have patients who either are not a surgical candidate or just don't want surgery. We have a great colleague that we use, Dr. Kendra Lynch out in Cairo, and she really specializes and is board certified in metabolic weight loss. And so while we are here to help take care of you, we are absolutely not trying to convince anyone that they need to have surgery. We're just a tool to help you on your pathway. So even if it's something that you're interested in just getting to see someone to help you with medicines and really working on your weight loss without surgery, we also have that as a part of our program. So candidates for weight loss surgery. You have to have a BMI of 35 with a comorbidity that is significant. That includes diabetes, heart disease, high blood pressure, something of that matter. Or you can have a BMI of 40 and you don't need any comorbidities for that. We do want to make sure that you're healthy enough to undergo surgery. This is an elective procedure, so we don't want to put anyone at risk for premature death. So that means patients with uncontrolled CHF or uncontrolled COPD may not be candidates for surgery. It's something we just have to address on a patient-to-patient basis. We always have to document failed attempts at weight loss. Patient cannot currently have a drug or alcohol problem. We have to make sure it's definitely not doesn't count you out for surgery if you do have something like depression or anxiety or bipolar disease. We just want to make sure that that is optimized so you can do the best you can with the surgical procedure. We also have a team of GI doctors, pulmonary doctors, cardiologists, and myself, as well as nutritionists, that look at all these factors to make sure that you're a good candidate and ready for surgery. So I put this procedure in here because it is a common procedure to have been done in this community. I will disclaim that I myself have never placed one of these in because we have found that they aren't quite as effective as our other options. But I do have a lot of experience managing them themselves, and then also I have taken a great number of them out. So I just wanted to add this in case someone did have this procedure or knew someone that had this procedure. We do it laparoscopically. It is a fairly quick and fairly minimally invasive procedure with low complication risk. We do find patient lost about 40% of their excess body weight, but we also found that that weight often came back. There's a subpopulation of patients who do well with it. For the most part, it doesn't work that well. So this is one of the two procedures that we offer here. It is called a sleeve gastrectomy. This is the most common bariatric procedure done in the United States right now. It's a great procedure. It was initially performed as a part of a 2-stage procedure for very large patients over a BMI of 70 even. And they would do this procedure and they would lose so much weight that they sometimes didn't even feel the need to do the second part of their original procedure. And so this has become, over the last 15 years, a great standalone procedure that we have consistently been able to see 60% of excess body weight loss at 1 year. And then we also have some 5 and 10 year data now saying as long as the patient continues with their lifestyle changes, continues with their follow-up, continues with the support group, they keep 50% of that excess body weight off, which is really, really great. There's no implantable device. The procedure itself usually takes less than an hour. And I think it's a really good operation. We talked about that a little bit. The other operation that we do offer here is Roux-en-Y gastric bypass. This is something that's done either laparoscopically or robotically, just like the sleeve. This is still the gold standard for weight loss because we know that it works and it has a very small complication profile. Excess weight loss is a little bit higher at 70%. There's no implanted devices again, and again, there's a very low complication rate. Patients that I think this is a little bit better for are patients who has a BMI that is over 55, and if they have been on insulin for a long time with their diabetes, the bypasses actually has a little bit better resolution of those symptoms. So we basically create a very small pouch that's 1 to 2 ounces, and then we reroute the small bowel so that the first 100 to 150 centimeters does not have any of the digestive juices. So it's both restrictive and malabsorptive in that manner. So just to kind of go off track just a little bit, there are a lot of bariatric procedures that are offered other than what is up here. There are things, intragastric balloons, which are a temporary weight loss measure, not covered by insurance. There is a biliopancreatic switch, which is the second part of that sleeve operation. There are new things like embolizing some of the blood vessels that go to the stomach, which makes me just so nervous to think about. But there are a lot of options out there. These are the ones we offer because we know that they're safe and we know that they work well. So once a patient gets into our clinic and starts with us, they have a 3 to 6 month process depending on their insurance, mostly guides if that goes towards 6 months. We work with them on changing their diet, making good changes, exercising, increasing their ability to prolong their exercise slowly over time. Like I mentioned before, they meet with a dietitian at every visit they're with us. All patients, no matter what insurance, get a psych evaluation because it is required for all insurances. It also helps us to make sure that a patient's ready, understands what's going on, and is at the best time of their life to undergo this big change. Usually patients don't have to lose any weight, but if there is a difference on their anatomy that requires that, sometimes they'll have a weight loss goal. If the patient has any reflux at all, we get an EGD, we get sleep studies, and we make them go on a clear liquid diet for a couple weeks to shrink their diet before surgery. The reason we do that is because it makes it safer for us. It decreases the complication rate for the patient. When you're in the hospital, patients are in the hospital, they're started about on clears that day. The biggest issues we see are that they're nauseated and they have gas pain. Our patients just last week did really, really great actually, and then we're able to be controlled that without any issues. We make sure patients take in so much fluid before they go home so they stay hydrated and they do well. Just so we can kind of think about long-term things. At 3 weeks, we hope the patient is going back to normal activities. They can return to work at 3 weeks, sometimes 2 weeks, depending on their job and how well they're doing. We want to help them plan for their dietary needs at work because that is a big adjustment. You have to be able to get to water because you have to drink throughout the day, and we have to have your meals planned out because you're on very specific foods. We have physician and nutrition follow-ups basically for the rest of their life, but we follow them very closely immediately at 3 weeks, 3 months, 6 months, and then yearly to make sure that they're doing well. And then we have a monthly support group that everyone, whether they want surgery or just interested in losing weight, all of our patients are invited to. The reason that we know that this works, the reason that insurance is well covered is because we do find very significant decreases in the comorbidities that were associated with that obesity. We can see that specifically diabetes, hypertension, and sleep apnea makes a huge difference. But if you look at these issues with both the sleeve and the bypass, I just want to mention again, the bypass does have a little better resolution of that diabetes. So just a little bit about our program. I am a fellowship trained surgeon. I'm really excited about this program and I really love it. I am the only fellowship trained up to this point, but we have another bariatric fellowship trained surgeon who's coming in September. So there will be 2 of us as a part of this program. We do all of our surgeries here. We do all of our patient interactions here. We are currently set to be able to apply to be a center of excellence after we do the appropriate number of cases. We have all of everything else in place, and we would be the only center of excellence in this area. We also luckily have 6 surgeons, so one of us is absolutely always on call, and we can always help with any needs that you might need at any time of the night. So things that we consider before embarking on surgery are age, health risks, how much weight we want to lose postoperatively, the lifestyle changes that we're going to have, and eating behaviors. The decision on which surgery a patient gets is 100% up to them. I give them all the information I think they need, and I help to guide them, but if a patient, whatever operation a patient wants, then that's good as long as it's safe for them. They can go and proceed with that. Part of what we do too before you get to see us is we make sure that your insurance does cover both the procedure and me. To make sure that you're not having any out-of-pocket costs, as minimal as we can anyway. If that were not the case, then I would help you find someone who was in your network. Have any questions? I'll give you an estimate for cash. Cash out of pocket would be approximately $16,500, but that's just that's if you're a cash paying patient. Like I said, almost all insurance cover this operation. And so what we would have to do is look with your specific insurance and call and ask, how much is covered, what's the co-pays on each visit, how much deductible do you have to meet? And so it's different for each person. The procedures are fairly similar, actually, between the two as far as cost. One, the bypass may be a little bit more, but not much.
Could you go back to the last one?
Yes.
Thank you.
Yes.
They got a 5-year wait list.
That's just for some insurances. So I like to put the worst case scenario on all of them. Some insurances don't require that at all. In fact, most of the ones we've been working with haven't, but I like to put the worst case scenario so that you're aware of that. But I've had one insurance so far that's required 3 years, and then I had a 5-year in Maryland. But for the most part, our insurances, as long as they're spending 3 months with me or with someone else, and they have all the other requirements, I haven't had an issue.
Suggestions for patients as far as if they lose the weight too fast and have if they have
Yeah. So that's a great question. Once we get to that point, usually our weight stabilizes after these operations at about a year. So that's whenever you kind of know what everything's going to look like. We have some great plastic surgical options. I would tell you there's somewhere in Tallahassee, there's one plastic surgeon here, and so we would find the right fit for you for what you need. But yeah, that's definitely something that can help. And we have to kind of work with the insurance companies. Again, some cover it, some don't, but usually we can find a reason to help with that, to get that covered.
What type of medicines do you all offer for non-surgical, people who are interested in non-surgical? I know you said you mentioned medicines that you all could give us to help us lose the weight. What type of medicine?
Yes, ma'am. So I myself I prescribe Adipex. I know some people don't like that because it makes them jittery and have problems with it, but most patients do okay with it. If a patient is interested in doing that metabolic route, I actually send them to Dr. Lynch, who specializes in medicine prescribing and also other ways to lose weight. And so if the Adipex doesn't work for them, I usually prescribe them to the specialist. I know that she uses the concave medicine sometimes though, and that's been good. BMI, body mass index. Body mass index. So body mass index is a measurement based on your height and your weight. Oh, so what we would do is we would take your height and your weight, and those both numbers go into making your BMI. We found that that's, as medicine as a whole, not me, but has found that's the most consistent way to be able to assess how much extra weight you're carrying. So people can be different weights and different heights and still not be in that spectrum. If they're tall and they're 200 pounds, then their BMI is probably around 34. Whereas if you're my height, then it's different. All right, well, thank you everybody for coming. If you do want me to call you and give you some more information, if you have any other questions you'd like to ask in private, or if you're interested to come see us, fill out that little paper and I will be giving you a call.